This is Brent of the Brookbush Institute, and in this video we're going to go over a joint-based manual therapy technique. If you're watching this video, I'm assuming you're watching it for educational purposes and that you are a licensed professional with joint-based techniques within your scope. That means osteopaths, chiropractors, physical therapists, you're probably all in the clear. Physical therapy assistants, athletic trainers, massage therapists. You need to check with your governing body in your state or region to see whether this is within your scope of practice. Personal trainers, this is definitely not within your scope of practice. Of course, all professions could use this video for purely educational purposes to help with learning biomechanics, anatomy, and of course, palpation. This is Brent of the Brookbush Institute, and in this video we're going over thoracic spine mobilizations, that's posterior to anterior mobilizations, also known as PAs, and transverse mobilizations. I'm going to have my friend Melissa step out. She's going to help me demonstrate. Now, the first thing you'll notice is that she's going to lie prone and that I have the table fairly low. The table is low for these posterior to anterior mobilizations. I want to be able to get my chest over her thoracic spine with my arms straight so that I can use the weight of my torso and not my hand strength to try to do these mobs, which would wear out my hands pretty quickly, I think. Now, before we get into the techniques themselves, it is important that we cover anatomy and palpation. And of course, your knowledge of anatomy is going to determine how good you are at your palpations. For those of you guys just starting out, I would have you start on bare skin. Remember that clothing is just one more layer of stuff to feel through. For those of you guys who've done mobilizations before, you kind of have a good idea of your palpations, you've been doing some release work. I don't think a gym shirt like this is much of an issue, so I would actually do therapy right through this fairly thin shirt. I wouldn't want to do it through a sweater, but a thin workout shirt like this should not be a problem. Going back to our anatomy now, remember that your thoracic spine, by definition, is all of the vertebrae that your ribs attach to. So you can think this huge stable rib cage, that alone is going to add a lot of stability to the thoracic spine, which to us as manual therapists is going to feel like stiffness. Right? The thoracic spine tends to feel fairly stiff even when compared to like unilateral PAs of the lumbar spine, and of course when compared to the more flexible cervical spine. Now, finding the thoracic vertebrae, if we wanted to create our borders, we could find the spinous prominence of C7, that big bump right at the bottom of the neck, right? So I know if that's C7, then T1's right here. And then of course we could find rib number 12, and hopefully Melissa isn't too ticklish here, but if I kind of follow T12 on up to, or I'm sorry, follow rib 12 on up to T12, I can find my last thoracic vertebrae, right? So there we go. There's my thoracic spine. Now, I would recommend looking at an anatomy book, maybe one of these plaster cast models, and start trying to think about how the thoracic vertebrae differ from the other vertebrae that I've put my hands on. So maybe you've already watched our lumbar spine and cervical spine, posterior to anterior mobilization videos. You'll notice that the cervical spine, and the lumbar spine for that matter, the spinous process goes fairly straight out. It's almost in line with the facet joint. And then you look here to the thoracic spine and you notice they all look bent down, right? So they're very, very angled. So some things that does that's a little different, right? Whereas this feels very pointy up here when you go through the spinous process. And we talked about the lumbar spinous process. They feel like flat and then divot, flat and then divot, flat and then divot. The thoracic spine feels much more like this under your fingers if you like just palpate down, right? It just kind of feels like this curve like this, like you've seen pictures of sinusoidal curves or like sound waves, right? So you got those type of bumps. The other thing you're going to notice real quick is if you feel the end of a spinous process, it doesn't match up to the facet of the same segment, right? So if I wanted to, let's say, do a transverse mobilization and a unilateral posterior anterior mobilization on the same segment, I'd have to go from here to here, right? So it's going to feel like 1.5, almost 2 segments away from the end of that spinous process. And I'm going to show you guys a way to kind of feel that out so you don't necessarily have to remember that, you know, it's 2 away. That's a good thing to remember, I guess, but the better thing to do would be able to test it with your fingers, so that whether it's 1.5, 2, or 1 away, it doesn't really matter because you can palpate it. Now the other thing to think about, and although it's not really clear on this particular model, is that the transverse process of the thoracic spine feel much shorter this way. It's probably partly because they're angled up a little bit. Right? The ribs kind of come up underneath them, right? So that might be part of why their angle is a little different. But they definitely, the ends of those definitely feel closer to the spinous process. So already we're starting to see our palpations are going to be a little different. This is going to be smoother bumps. These bumps aren't going to match up to the facets. The end of our transverse processes are going to feel much closer to our spinous process, and our facets actually are going to be between those 2 points. So you're literally going to fall right off a spinous process and then look for your bumps to do your mobilizations to get over those facets. All right, of course, your rib cage, you can actually feel this, comes this way, and you have your transverse costal joints and you have your costovertebral joints here, right, that come in this way. You can actually feel the ribs dive underneath the transverse processes. All right, so that might be a good place for you to start your palpations, or for us to start your palpations. So what we just looked through on that, let's go through real quick, and I'll show you guys that again on the close-up recap. If I just feel Melissa's rib cage, right, and I'm just using broad hands here, right, and feel all those bumps, and I just feel one of the ribs, and I just slowly palpate up. And I make sure that I'm palpating through the soft tissue. I'm keeping on those bones, right? I can actually feel right here, I run into bone. And I know you guys can't see this yet, but we'll again see this on the close-up recap. I run right into her transverse process. So I can actually even take this hand now and put it over the rib and press down and feel like a ledge like this that's the transverse process, and the rib kind of do this underneath it. All right, so now I got rib, I got transverse process, I got a little bit of a valley, and then I got a spinous process right in the middle. All right, so that gives me some good landmarks. I got rib, transverse process, valley, spinous process, and I can feel that if I go down them, it's smooth bumps like this. All right, so now we get into, what am I going to mobilize? Well, I want to be able to feel stiff segments, and sometimes the easiest way to feel through what segments are stiff is using something called a central PA. Now for a central PA, we want to push down on the spinous process, posterior to anterior. What I'm going to use generally is, I'm going to use my pisiform hamate grip, right? So I'm going to put her spinous process right here, right in this meaty portion here, right around my pisiform. I'm then going to saddle my fingers around the top of them, and I can kind of press down until I run out of motion. And I can ask Melissa, is that pain or pressure? Lots of pressure, no pain. And as well as I'm going down the various spinous process here, and notice guys, I'm kind of going a little bit in this direction too. We got to think about how those facet joints are shaped, right? They kind of do this thing, right? They're pretty flat this way. Right, how does that feel? That feels okay. I can also take mental note of, does part of her thoracic spine feel stiffer? So the thoracic spine as a whole is going to feel stiffer than maybe our lumbar or cervical spine, but is there a segment or segments in her thoracic spine that feel stiffer than others? Like maybe she's really stiff up in here. And the only way you're going to get a good idea of what that feels like is, one, comparing it to other parts of the spine, and two, you're going to have to palpate a lot of people. You're going to have to do this on a lot of people and start creating your internal frame of reference of what normal is based on your techniques that you use consistently. So Melissa to me feels a little stiff up in here. So now what can I do? Well, I could use my central PA as a technique. So I could drop right back into this position, right? Arms straight, use this grip. Notice that my chest is over my hands, and now I'm gonna find my first resistance barrier. I'm gonna find my end range. Now that's arthrokinematic end range. You gotta push them all the way to the end of their joint. It's not going to be necessarily very comfortable for them. Right? And I'm gonna back off to 50%, and then from there, I can start with my first end range to just around 50% of resistance, grade 3 mobilizations. Right? 1 to 2 oscillations per second if you're using kind of a Maitland-Cyriax approach like I do. And of course, I'm going to keep doing this until I feel a change in the amount of stiffness. Usually that's around 30 seconds. All right, so make sure you follow through and do as many mobilizations as it takes. It could take up to 2 minutes, 1 minute to 2 minutes of mobilizations like this to really get some significant change depending on how stiff they are. If you feel like they might be irritable, of course you could start with a few seconds, like let's say 5 seconds of mobilization, let off and go, hey, how do you feel? And if they're still feeling pain, then you know this might be a person that you have to start off gently with, just do a little bit of mobilizing and go ahead and let them sit up and retest. So that's central PAs, guys, and all I'm doing is finding the end of the spinous process, hooking my pisiform portion of my hand in there, right? This nice meaty part right here. I'm gonna hook it in and then do my mobilizations. And I could do the entire thoracic spine if I thought the whole thoracic spine was stiff. I'm just gonna go ahead, palpate, move down one, put my pisiform over it, boom. Palpate again, and all I'm doing is taking these 2 fingers and putting the spinous process right between it, moving down one, and boom, do it again. All right. What other options do I have? Well, I could try to get down to the facet joints, realizing that the facet joint, if I'm trying to do the same segment, I have to move up, right? So the spinous process, this spinous process is actually attached to this facet. I don't know if you can see how far my fingers are apart, but that's a fair distance. That's for me a good 2 fingers width. There's actually almost 2 spinous process between. So I can go, if I take that's one spinous process, I can go, here's my next one, here's my next one. If I drop off laterally and inferiorly, so I drop down just a little bit like that, that's where the facet connected to this spinous process is. Right, so what could I do there? Well, I can do a bilateral PA. So a bilateral PA, you're gonna put 2 fingers over those facets like this. These become dummy fingers. They don't do anything but hold your place and feel. You're gonna use this hand and go over the top, and that's gonna create your pressure. Right? Same thing, first resistance barrier, last resistance barrier, back off. And maybe this time I want to do grade 4. So I'm going to do small oscillations at 50% plus of resistance. All right, so that's one way to do bilateral PAs. The other way I could do bilateral PAs is the crossed thumb technique, right? So I could do this. Now, I've mentioned this in other videos. For me, if I can get away with not using my thumbs, I don't use my thumbs, because there's way too many techniques that are completely dependent on your thumbs. Like there's just no other ways to do it. So you want to save your fingers as much as you can. If you were in a difficult situation though, and you felt like you were having a hard time just palpating what you were supposed to feel, maybe you're having a hard time sticking to the facet that you know is stiff, right? Maybe somebody has some weird anatomy, like you don't feel like things are matching up, and you feel like your thumbs are your best tool, right? So you can do something like this. We could go this way if we had to. We can go this way, or you saw what I was just doing was this, right? This is a little bit more difficult, but could be done. What else could I do? Well, we could go back to our workhorse of spine mobilizations, which is UPAs, and I've talked about this a lot. These are the unilateral posterior to anterior mobilizations where you're focusing on one facet joint at a time. And again, all I'm going to do is find that stiff segment, right? Think about, okay, well, if I want to affect that facet, maybe I have to find the right facet, right? So I was just on that spinous process. If I keep pushing on that spinous process and then move my thumb around until I feel that facet move under my other thumb, right? So that's right about there. I can then use my thumb over thumb technique, right? Just like so. I could use kind of a dummy thumb pisiform grip. So here's something that I see a lot of people do, although I don't see it in textbooks as often, is I'll use my thumb as my dummy thumb and then put my thumb in this pisiform point like I was doing with the spinous process and go right over the top just like so. And I use that really commonly in the thoracic spine because there's so much muscle to get through. And Melissa's so jacked because of all the weight training she does, right? So I can go right in there. And could I use other fingers? Potentially. Like I could use maybe, you know, if my thumb was getting beaten up, maybe I go back and look like I'm setting up for that bilateral PA, but only putting my hand over one finger. That's not very comfortable for me, but it is a possibility. All right, thumb over thumb. And then the question is, well, what else? What else could you do? Well, you could do transverse mobilizations. So hopefully you guys are following me here. We went from CPAs, which is on the spinous process, to bilateral PAs, which was this, like so, or double thumb technique, which I'm not actually necessarily recommending because we don't want to wear out the thumbs. You could then do UPAs, which are probably the workhorse and the thing I go back to most often. But another thing that's helpful in the thoracic spine, and I almost use it exclusively in the thoracic spine. It's actually very rare that I would even try this in the lumbar spine because of how stiff the lumbar spine is. It's very rare that I try it in the cervical spine because I just don't need it. But these transverse mobilizations come in real handy for the thoracic spine, and especially the upper thoracic spine for whatever reason. So if you're going to do a transverse mobilization, let's think about this for a second. You'll notice I'm raising the table way up because what I'm going to try to do is I'm going to try to push the spinous process this way. By pushing the spinous process this way, I rotate the whole segment. Right? Hopefully you guys can kind of see how that would work. Now the problem with transverse mobilizations is they also can be very hard on your hands. It's very hard to get a grip on one of these vertebrae. Now I'm actually going to drop Melissa's head down a little bit so I have access to these upper thoracic segments. But I'm going to find my spinous process, and then I need to do a couple things that are kind of interesting here. I'm going to use my dummy thumb, and I'm going to grab a little bit of skin. All right? I'm going to actually pull just like this, right? Like I'm going to gather up some of her skin and press it into her spinous process like so. So if this was the bone that I'm feeling, like I want to gather up some skin and then push it up against like this, because if you don't and you start pressing into a transverse mobilization, you're going to stretch the skin on one side and it's going to feel really uncomfortable. So let's say we're doing C7 and T1, all right, which is right there. So I'm going to go on T1 here, grab a little bit extra, and then I'm going to take this hand, I'm going to go like this. Now my force needs to go that way, so I actually might have to drop down a little bit, like so. And then you can see I actually have my hand on Melissa's head so I don't push her head too. Right? I can kind of stabilize her head. I can put the rest of my hand down here on her back, and then I'm just going to go this way, feeling for where's my first resistance barrier, where's my end range, and I'm telling you guys right now, this is not an easy thing to feel. This is going to take some practice. But once I find it, back off to my 50% mark, and again, I can do my grade 4s or my larger oscillation grade 3s, just like so, until I get some good increase in mobility. And I can keep going right on down the spine again. Feel my next spinous process, and like so. Just remember, guys, you don't want to do this. So this isn't a transverse mobilization. This is like an oblique PA. You got to be very careful what your intention is. Like if you're trying to do transverse mobilizations and you want more motion out of your facets, but then all of a sudden you're doing an oblique PA, you might actually just be closing down on facets, right? You might be doing like some sort of kind of smashing thing. And so we got to kind of keep these angles in mind, and I don't want to go too far down the biomechanic thing, because I know research has shown that our biomechanics aren't as consistent as we might hope they were as physical therapists, but do be aware of the angles that you're using, if for no other reason than reliability, right? If I did it this way this time, and then I had the table lower next time, so it was way up pushing down like this and calling it a transverse, and then the next time the table was high and I was doing this as a transverse, those three things are not the same. So let's run through those techniques one more time, because I just threw a bunch of stuff at you guys. All right, so remember your thoracic anatomy. Try to keep this stuff in mind as you're doing all of these various techniques. Your thoracic spine is attached to your rib cage. That's going to make it a little stiffer. One thing you might also want to think about with the thoracic spine and being attached to the ribs is you probably want to keep somebody's hands down, because if they put their hands up, can you put your hands up real quick? If they put their hands up like this, it's going to posteriorly tilt their scapula, which is then going to press down into their rib cage, which then could extend their spine further, and none of this is going to feel the same anymore. So from a reliability standpoint, you need to be thinking about that. Like, you might be able to get used to somebody's hands being up all the time, but that means every patient that walks in is going to have to start with their hands up. Whereas if you start with their hands down, then you don't have the posterior tipping of their scapula, you don't have that change to their rib cage, you don't have the change to their thoracic spine, and this becomes your norm. So be aware of little things like that, right? Know where your thoracic spine starts, so right under spinous prominence, C7, right? And know where to find T1. And then, of course, where's the spinous process? Right down the middle. Make sure you can feel all those. Make sure you're very aware that the facet and the end of the spinous process don't match, right? So your facet is almost two spinous, tip of two spinous process away, right? We talked about this was one spinous process, and then you had this one, and then I actually fell off this way and found our facet for this spinous process. And then your transverse process are actually a little shorter this way. So if you are palpating and you feel like you're going to feel a canyon and then a big bump, you don't want to go beyond that bump, because if you go beyond that bump, you're just mobilizing her ribs, which is fine if your intention is to mobilize her ribs, but if your intention is to mobilize her thoracic spine, then that's not going to work very well. Now, I showed you a bunch of techniques. We did central PAs, which I used this grip. Could you use a two-thumb technique? Of course, you could do this thing. Again, you guys know that personally, my feeling is if you can get away with not using your thumbs for any technique, don't use your thumbs, right? Because there are techniques, like I said, where you pretty much are stuck only with being able to use your thumbs. For example, unilateral PAs, you are kind of stuck on this technique. You could try to do the unilateral over a different finger, but it doesn't feel very comfortable. All right, so we tried central PAs with the pisiform hamate grip, right, which I said was like this. And that worked out pretty well. And then we did bilateral PAs, which would have a very similar effect to a central PA. But we did that with two fingers. Those two fingers, of course, would end up higher, right, if we were trying to do the same segment. And then I used this hand over those two fingers. And that can come in handy. That can definitely come in handy. You feel like you're just not getting it. Maybe the angle of the spinous process on this person is just messing you up, or they're really, really thick, or maybe they're really, really tiny, and this just isn't comfortable. Okay, let's try this technique. Then we talked about unilateral PAs, right? And then we just did our thumb over thumb. Oh, that's a nice stiff facet right there, okay? And then, of course, with all these techniques, we found our resistance barriers, 50%, all the way down at end range. Our first resistance barrier, I should say, end range of arthrokinematic motion. I can't press this joint any further, and then back off to 50%. And then I can either go 0 to 50, 50 plus, or I can stay at 50, 50 plus for a grade 4. All right, so that's my unilateral PA. We did talk about doing like a dummy thumb and pisiform for that. You could do that. Just be careful not to beat up on your thumbs too much. All right, this can be a little uncomfortable too. And then the last technique we talked about was transverse mobilizations, which do tend to come in handy for the thoracic spine, especially the upper thoracic spine. Right, and with that, you'll notice I'll get the table as high as I can because I really want to be consistent and try to create a horizontal force this way so that hopefully all I'm doing is tipping essentially the vertebral body there. We don't want to be inconsistent and start creating oblique angles that are going to be this quasi turn, quasi PA, quasi frontal plane smash into the other facet joint. Although that can be a great technique, right? There are things called super close techniques, right, for facet joint mobilizations. The big thing is whatever you're going to do, you got to be consistent. So if we're going to do transverse mobilizations, let's truly be transverse. You're going to pick up all the slack on the skin around it. You're going to use that dummy thumb. And then with your other thumb, you're going to push straight this way. And like I said, guys, you can see that I'm up in her upper thoracic spine or cervical thoracic junction. This is where I find I use these particular techniques most. And part of that might just be because I can then come around this way. And what I'll do is I'll go, here's one spinous process, let's say C7. Here's another spinous process, T1. And I can do this thing to them. And I can actually check how mobile they are. All right, so let's see, does that feel stiff? That feels a little stiff. All right, let me get set up, do my mobilizations, and then I can retest. I know palpation may be my least reliable assessment, but while I'm doing my manual work here for a few minutes, I can kind of keep retesting and working on different facets, and then I can have her sit up and do whatever my more reliable assessment, in this case maybe goniometry for lateral flexion, right? Or whatever I found to be her concordant sign, whatever test provoked her symptoms, I could go back to that. All right, guys, so there you have it. Work on your palpations, know your thoracic anatomy, and then start slowly working through central PA, bilateral PA, unilateral PA, and transverse mobilizations. Stay tuned for the close-up recap. Our close-up recap, guys, here I have Melissa's thoracic spine. Down this way, we talked about finding the first thoracic vertebrae by finding spinous prominence at C7, which is right here, and then this is T1. All right, so you can tell, like, if I kind of move this way, hopefully you guys can see my finger kind of bump up and down. And you can see that if I depress my fingers, I can go right around a spinous process, just like so. So that's how I'm going to kind of identify these spinous process. I can move out a little bit, and I find another big bump right here. This would be the edge of a transverse process, and if I fall off that, I would get into the rib cage. All right, so spinous process, transverse process, rib cage. Between my spinous process and transverse process are those facet joints I'm going to want to be able to get into. Now let's talk about our hand positions here again. So we did central PAs, and what I did there is I found a spinous process. I put my pisiform hamate part of my hand over that spinous process. I saddled with the other hand, got my arms straight, my chest over, and then of course found first resistance barrier, end range, backed off to 50%. And I could do my grade 3s, which are my larger amplitude, or I can go a little more intense and do my grade 4s, which are small amplitude. We talked about bilateral PAs, which is where I'm going to get my fingers over two facets. Now, if I wanted to mobilize the same segment, I have to realize that the facet for this spinous process is actually probably closer to like up here, right? And the way I'm going to find that is I can go up two spinous process and then fall lateral and inferior, or I can do a little transverse mobilization with this hand, right? You guys see that? And I can wait to see, move my thumb around until I feel the facet joint under that thumb move a little bit. And I got right there. Right there, I feel, if I push on this spinous process, this moves. All right, so that's a little check for you guys. Now, I can do my bilateral PAs first, and we talked about this hand position, right, like this, and then putting this hand over like this. Once again, straightening out my arms, torso over the place I'm trying to, or chest over the segment I'm trying to mobilize, and then I can do my oscillations. We did unilateral PAs, which is thumb over thumb. All right, same thing. And then of course we did transverse mobilizations here, and these are the special ones, right? So this one is where I would normally raise up the table and then I would try to get my arms horizontal, and I'm actually pushing that way, right? So I have to take up a little tissue slack. You guys see how I did that? I took up a little tissue slack. I just kind of ran my finger over the top of the spinous process, and then this becomes my dummy thumb. I'm going to push with the other hand, transverse, just like so. All right, guys, have fun practicing. So there you have it. Assess, address, reassess. Make sure that every time you choose a joint-based manual therapy technique, it is based on an assessment, and that you return to that assessment after you finish the intervention to see if it was effective for the individual, the patient or client that you have in front of you. Ensure that you continue to learn your anatomy, because your anatomy is going to help you with your hand placement, with understanding what a joint can do, with understanding what you may gain from this particular technique. And of course, practice. You have to practice these techniques, hopefully not for the first time on a patient or client who just walked in the door. If you can, find a more senior instructor or a mentor to give you some really good hands-on instruction. Use your peers for some good feedback. And of course, always look for live education to help with your manual therapy techniques. I know these videos make education very convenient, but there is no substitute for learning manual therapy in a live setting. I look forward to talking to you guys again soon.